Dr. Syed Harun.
Thank you, Mr. Speaker. Before I begin my adjournment motion, I would like to declare that I am a consultant psychiatrist in private practice. I hold a visiting consultant psychiatrist appointment in a restructured hospital, and I am the Honorary Secretary of the Singapore Psychiatric Association. Mr. Speaker, I will begin this motion by saying that the state of mental health care in Singapore has improved over the years. There is greater awareness of mental health issues, wider efforts at integrating mental health into primary care, a readiness in the use of telehealth, and a greater appreciation and initiation of mental health initiatives amongst youth. There is also greater emphasis on research and local data to help inform policy decisions and allocate resource to areas most in need. Since July 2021, we have had the Interagency Task Force on Mental Health and Well-being look into 3 focus areas. The first of which relates to improving accessibility, coordination, and quality of mental health services. The second, seeking to strengthen services and support for youth mental well-being. And the third, to improve workplace well-being measures and employment support. My motion speaks most loudly to the first focus area and how I think we can and must do better in delivering mental health care and make it accessible to all. Mr. Speaker, on the theme of accessibility, being the first world country that we are, it cannot be the case that we are satisfied when accessibility means merely making available a path from point A to point B. A path itself is not enough for it to be called accessible. And taking a leaf from the transportation industry, to get people and goods from one destination to another, we pave ourselves a myriad and network of walkways, of park connectors, of roads, of tracks and expressways, underground, on the surface, and above ground. We maintain them to a T to prevent potholes and disrepair. And we want to make the journey smooth for our road users to get to their destinations of choice, so that when they reach the destination, they are comfortable and they are ready for their intended tasks, rather than be exhausted from the navigation of the journey itself. We ensure there is timely intervention and quick removal of barriers for traffic to resume, especially during peak hours. And we also manage the capacity of our transport systems to ensure we are able to sufficiently absorb the demand on a daily basis. There are clear alternative routes and diversions available as part of the forward planning in the transport infrastructure, and to our best efforts, we also ensure that transportation and people movement are safe and compatible with the users of the day. Mr. Speaker, in relative terms, when compared to what we can and have done for transport, I put it to members of the House that we can do better in terms of accessibility for mental health care. First, accessibility means that at the time of need, there is reasonable, expedient mental health care, and there is capacity in the system to be able to accommodate. We need to ensure our lanes are wide enough to receive, and the roadside lamps are up, and the potholes are cleared for passage. A parliamentary question was filed in July this year by the honorary member, Mr. Yip Hon Wing, on average waiting times and follow-up appointments for mental health treatment at public healthcare institutions, wherein the ministry responded that on the basis of median time, it takes 45 days to see a psychiatrist and 42 days to see a psychologist. Depending on whether one sees it as half empty or half full, it means that 50% of all cases referred to see a psychiatrist or psychologist wait no less than 6 weeks before an appointment can be arranged. I would be interested to see what our mean numbers are, because there could well be a long tail in terms of the waiting time for patients to get professional help beyond the 50th percentile. Even, Mr. Speaker, if we take a conservative and reasonably optimistic view that perhaps the remaining 50% are seen within 8 weeks, or by the second month from their referral, it is also worth noting that by the time patients need to be referred by the learned general practitioner to a psychiatrist or psychologist, it is likely the case that these patients are already struggling and are having marked difficulty in their lives. I would argue that a further 6 to 8 weeks wait for access to a psychiatrist and or psychologist is much too long a wait to bear. For psychiatric departments in restructured hospitals, manpower and infrastructure continues to be stretched to address the increasingly complex medical psychiatric cases, cases involving vulnerable adults and those lacking mental capacity, cases where trauma, cancer, strokes, infectious diseases, and endocrinological illness overlap with mental illness. There's much complexity in the treatment of psychiatric conditions. Our restructured hospitals have organic psychiatric departments that are smaller, yet the range and depth of complexity of the cases and the need for interdisciplinary work across specialties are no less challenging. Not all restructured hospitals have dedicated infrastructure and a ward for psychiatric patients, and this makes managing even patients who are of moderate risk sometimes difficult in a restructured hospital setting. We can do better. Secondly, accessibility also means that there are limited resources within the public healthcare system, alternatives need to be possible and readily available. Now, we're not saying that every time we need to get to the destination, it must be the expressway all the time. But where that is not possible, fair and ready alternatives should be within reach. Mr. Speaker, I can appreciate that there is a utilitarian view to the delivery of public health care, with which practical considerations and a desire for the system to deliver the greatest benefit with the limited resources that it has. However, for patients suffering from mental health conditions, they find themselves also stuck between a rock and a very, very hard place. For many of them, to search for alternatives beyond what is available in the public healthcare system remains both a rarity and at steep expense. In our last September parliamentary sitting, the House would recall honorary members Dr. Tan Wu Ming and Ms. He Ting Ru asking about insurance coverage for individuals with mental health conditions. Yet the response from the ministry, in my humble view, skirts the point. While I'm grateful that Singaporeans and permanent residents are covered under MediShield Life regardless of pre-existing conditions, the tenor and the spirit of the questions were that of stigma and a lack of parity and transparency for patients who have a history of mental illness in procuring insurance coverage for themselves. There are challenges that people with mental illness face with insurance coverage that goes beyond the scope of their mental illness or the insurance underwriting on their risk of self-harm. Some find it disproportionately more challenging to secure insurance coverage even for physical health conditions, even though the specific mental health condition that they have or may have had in the past does not necessarily bear a correlation to the prospective risk of physical ailment per se. Mr. Speaker, we cannot paint mental illness with a broad brush. Sometimes depression can be the result of a temporary but extraordinary loss of a loved one, and the likelihood of recurrence may be no different from anyone here in the House. ADHD can be outgrown for many, with little reliance on medications into adulthood for some. Dyslexia can be overcome and strategies learned to manage reading challenges. Anorexia can be stabilized, self-esteem restored, and meaningful relationships blossoming thereafter. My proposal, Mr. Speaker, is for the government to study this issue more deliberately and have a deeper look at the evidence and reasons for refusing, for loading, and for making exclusions for insurance coverage relating to mental health conditions. Give each mental illness the proper airing and stratification it deserves. If we get it right, more people will be willing to get themselves insured. More people will take active steps about declaring their conditions, and many more others will start taking care of their mental health by seeking treatment early. Now, I'm not saying that insurance is the silver bullet to mental health care, but it signals to people that we take it seriously, that we want to prevent it, and that we want to make mental health care as accessible as possible, especially to those who take a keen interest in wanting to manage their health needs proactively. Thirdly, accessibility also means ensuring that we manage the intersections of mental health care well. Sometimes, even with the best roads, jams can occur if intersections are not well designed, or if traffic junction timings are poorly thought through. I'm heartened, Mr. Speaker, that the government has had a renewed push for Healthy SG, as espoused by its white paper, with an aim of 32 polyclinics by 2030 and an increase of public hospital capacity by 30%. In fact, just yesterday, a further 500 beds were added to the healthcare system as the Honourable Minister for Health initiated the opening of the Tan Tock Seng Integrated Care Hub. My hope is that in tandem with this increase in capacity, that the government takes heed to the increasing demand of mental health care in the coming years, and that alongside this, so too would the resources for mental health care improve and increase at both primary and tertiary levels of care. In wanting to improve accessibility through health and mind clinics, my hope is that all future 32 polyclinics will see mental health care as part of their staple baseline services by our family physicians. The government should also harness stronger lateral linkages across public, people, private sector partnerships as part of a layered approach to deal with mental well-being, mental illness, and mental health care. I also hope for better vertical integration of services such that the delivery of mental health care from community to hospital and then back to community can be seamless and less disjointed. Efficiency, Mr. Speaker, sometimes inadvertently means that the handoff gap from one point of care to another becomes narrow but steep, because the boundaries can be so well defined and mutually exclusive. I urge the government to consider some overlaps at the intersections of mental health care so that the patient journey is seamless and gaps are prevented by design. When care touchpoints become more coherent and less fragmented, the patient will feel that the intersections are less ominous and less overbearing, and that their last mile experience in this journey is one of care and deep concern. This directly ties to their confidence in the quality and delivery of care, their willingness to continue in the care journey, and that should they relapse again, they will have little difficulty in navigating the system to find their way to recovery. Fourth, accessibility also means accounting for socio-cultural needs and being sensitive to community-specific factors to mental health care. Not all vehicles are made the same, but every vehicle needs servicing, even as they each may be unique in some ways. Mr. Speaker, in dealing with the private and very personal nature of mental health conditions, compatibility of care to the cultural and religious and social influences of the individual needs to be considered as part of the ecosystem. It is not uncommon that symptoms of depression, obsessive-compulsive disorder, and psychotic disorders, much as they are recognized and established mental illnesses, take root, shape, and form in the social, religious, and cultural background of a patient. If we want to make mental health care effective, we must consider, as part of our system of care, a deep understanding and sensitivity to the different mores of cultures, faiths, and spirituality too. When practice of mental health care is devoid of this understanding, a diagnosis could be misinformed, treatment becomes suboptimal, medication compliance becomes poor, and a willingness for treatment is lost. In fact, it can be a barrier to seeking help altogether. Mr. Speaker, in Malay, please. Sebagai contoh, Tuan Speaker, dalam masyarakat Islam, ramai melihat gejala penyakit mental sebagai gangguan rohani, hasutan jin dan hal perilaku sesuatu yang gaib. Ini walaupun pada hakikatnya ia jelas tertera berunsur dan berputik penyakit mental. Sama seperti masyarakat dan kaum-kaum yang lain, usaha memberi kesedaran tentang penyakit mental kadangkala memang mencabar. Ia memerlukan kerjasama rapat dan rakan kongsi dari pemerintah, badan-badan kemasyarakatan, badan-badan keagamaan, dan agensi-agensi sosial. Perlu adanya perbualan yang lebih mendalam tentang kesihatan mental dalam masyarakat. Dan ia seharusnya menjadi buah bibir masyarakat sama seperti perihal kesihatan fizikal dan isu-isu terkemuka yang lain. Seiras dengan itu, semestinya masyarakat Islam juga perlu memberi keprihatinan khusus bagi meningkatkan kesedaran dan menggalakkan lebih ramai menceburi bidang psikologi dan psikiatri, kerana bilangan pakar dalam menangani perihal semasa ini amat berkurangan. Dalam menangani kesihatan mental secara menyeluruh, walaupun ianya bukan satu kemestian apabila mendapatkan rawatan, dengan adanya pakar yang memahami secara mendalam dan yang mempunyai kepekaan unsur-unsur perihal kebudayaan, ia membawa kepada kesenangan dan kemudahan bagi pesakit untuk meluahkan isi hatinya dan membentangkan masalah peribadinya tanpa khawatir diejek atau diremehkan keimanan, ketakwaan atau dasar kelakiannya. Mr. Speaker, through my own clinical lens, I have been educated by patients on their hallucinatory perception of visitations, of the occasional deity and spiritual disturbance, whether by Kuan Yin or an omnipotent God or a memory of a distant figure of the past. This is common across very many different faiths, cultures, and backgrounds. And often there is an overlay of mental illness that needs addressing and can be helped, not in isolation, but through partnership with community and religious institutions playing a part. Beyond medical-related factors, we must also recognize the interplay of culture, spirituality, faith, gender roles, and familial factors as potentially being enablers or barriers to seeking help. Other than children and the vulnerable in our midst, men and the elderly in particular should also be given some focus as we seek to make delivery of mental health care culturally competent and more accessible. Lastly, Mr. Speaker, accessibility begins at home and at the workplace. The process of seeking help is a non-starter when the home and workplace are apprehensive to or unsupportive of mental health care. It would be difficult for employees to seek help when the opportunity cost of declaring their mental health condition could be their entire employment. The oft-cited question is that of stigma and how can workplaces and employers engender a better culture of mental well-being. My response ordinarily revolves around the fact that it starts from our own day-to-day biases, how we respond organically and spontaneously to matters of mental health, and how sensitive we are to what we read and what we hear of mental health conditions. I am particularly optimistic by the announcement by the Ministry of Manpower in August regarding the upcoming workplace fairness legislation, especially in protecting against workplace discrimination for disability and mental health conditions. In this regard, I look forward to the details in place and the extent to which people with mental health conditions can feel assured regarding their employment. Beyond this, we must ask ourselves how we can do better on the rehabilitative mental health and improve outcomes for re-employment and reintegration of persons with mental health conditions. A negative prospect of returning back to their home and livelihoods will feed into people's fears of seeking help early, thinking that they may never return to full function, and that there are few opportunities for meaningful employment after a diagnosis of mental illness. To conclude, Mr. Speaker, I would like to take the opportunity to remind the House that World Mental Health Day is on 10th of October. I will confess that even as I filed this adjournment motion, I had forgotten about this fact, and I can only posit that it is serendipitous that a psychiatrist is here winning a ballot to speak on the issue of accessibility of mental health care in Parliament just a week before we celebrate World Mental Health Day. I urge members to consider your position on how you view issues related to mental health, its accessibility to care, and how some of our citizens at their most vulnerable hour struggle to get timely accessible care, lack reasonable alternative options to support their needs, and have valid worries about their employability after. Mr. Speaker, as a category, the lifetime prevalence of mental illness as reported in the Singapore Mental Health Study of 2016 stands at 13.9%. This is even higher than diabetes, which stood at 9.5% in 2020, on whom we rightly wage war against since 2016. I ask this House to consider the weight of mental illness on our society and measure its funding, resource, and accessibility to care accordingly. Like diabetes, mental illness is often silent and unseen. However, unlike diabetes, the impact of mental illness on quality of life is more immediate from the point of diagnosis, and the grind and burden on caregivers can be immeasurable and very quickly so. I look forward to this House taking steps to set the tone and example through the work that we do and engagements that we have to make mental health care more accessible for all. Thank you.
And there's a great maiden speech, Dr. Syed Harun, responding, SPS Rahayu Mazum.
Mr. Speaker, I thank the member, Dr. Syed Harun Abhabsi, for his passion and concern for the mental health and well-being of all Singaporeans. I'm also grateful that Dr. Syed has chosen to speak on this important topic in his maiden speech in this House. Mental health is indeed a pressing concern. The recent National Population Health Survey, NPHS, reported a rise in prevalence of poor mental health among Singapore citizens from 13% in 2020 to 17% in 2022. Younger adults aged 18 to 29 years old seemed more affected, with about a quarter of those surveyed reporting having poor mental health. The Singapore Youth Epidemiology and Resilience Year study findings released earlier this year also showed that 1 in 3 youths reported mental health symptoms such as sadness, anxiety, and loneliness. Good mental health is essential in maintaining overall health. A person's mental health and well-being is influenced by many factors such as pressures at work, school, poor relationships, etc. Addressing these issues will require a collaborative and integrated approach that involves multiple stakeholders from the health, social, education, workplace, and community sectors. Therefore, besides expanding healthcare capacity and investing in training of our healthcare manpower, we need to go beyond curing mental health conditions to prevention and tackle upstream factors through a holistic and coherent strategy. This move upstream means we can avoid over-medicalizing mental health conditions and instead invest our resources in the promotion of well-being and early intervention. This will help us to improve our overall health outcomes and reduce health inequalities across the population. For this reason, the Interagency Task Force on Mental Health and Wellbeing was established in July 2022 to oversee and coordinate mental health efforts across different sectors, focusing on cross-cutting issues that require interagency collaborations. The task force is chaired by Senior Minister of State for Health, Dr. Janil Puthucheary, and brings together members from over 30 public, private, and people sector agencies, including colleagues from the education, social, and workplace domains. Over the past 2 years, the task force has reviewed the landscape, studied gaps and challenges, and consulted the public and stakeholders. We have since put together a comprehensive national mental health and well-being strategy that charts our way forward to improve the mental health of Singaporeans, and we will be releasing a full report of the strategy in the next few days. Ahead of the release of the strategy report, allow me to provide some responses to the issues raised by Dr. Syed. We fully agree with Dr. Syed on the importance of taking an active approach towards ensuring accessibility and timeliness of care, capacity, and support structures around mental health. For this reason, we believe in preventing poor mental health upstream by equipping every Singaporean with basic awareness and literacy on mental health and well-being issues, and encouraging those in distress to actively seek help where needed. Efforts in this space include the Health Promotion Board's HPB Mind SG portal and the It's Okay to Reach Out campaign, which promote self-help and provide guidance on maintaining good mental well-being, such as managing emotions and stress. Beyond literacy and awareness, it is also important to dispel stigma and misconceptions around the topic of mental health and well-being. The National Council of Social Services, NCSS Beyond the Label movement, addresses mental health stigma and promotes social inclusion of persons with mental health conditions. We hope that through these efforts, we can build better awareness, improve understanding, and normalize conversations around mental health of Singaporeans from all ethnic and religious groups. Beyond general public education efforts, we have been enhancing community resources to make it easier for Singaporeans to seek help. For instance, well-being circles have been set up to provide citizens with the skills to care for their own mental well-being and that of others around them. In addition, community mental health teams supported by the government and set up by social service agencies provide mental health assessment and psychosocial help for those in distress. Many of these services are provided without charge to the residents. Specifically, for the Malay Muslim community, I'm leading a new focus area on community health set up under MCube, a collaborative effort between the Islamic Religious Council of Singapore, MUIS, Mendaki and Mesra. The aim is to rally the Malay Muslim community in promoting healthy living lifestyles and empowering them to organize and scale community-led initiatives. One of its priority areas includes supporting the mental health and well-being of the residents, taking into account their cultural context. We will leverage on this effort to bring across more mental well-being initiatives to the residents through further collaborations. We note Dr. Said's concerns on health insurance coverage for individuals with mental health conditions. Today, all Singaporeans are eligible for healthcare subsidies of up to 80% in the public healthcare institutions, and all Singaporeans and permanent residents are also covered under MediShield Life, regardless of pre-existing conditions, including mental health conditions. Some individuals may wish to purchase private integrated shield plans, IPs, and other insurance plans beyond subsidies and MediShield Life. Private insurers selling these plans are expected to deal fairly with customers and not to indiscriminately reject an application solely based on declared personal information such as occupation, income, disability, or medical condition, including mental health conditions. MAS will take action against insurers whose practices are in breach of MAS's regulations or guidance, and individuals with concerns over their insurer's underwriting decision can make an appeal through their insurer's feedback channel or through MAS. Lastly, we recognize the importance of workplace and employment support for individuals with mental health needs. On this front, companies are encouraged to tap on the various initiatives available, such as the Health Promotion Board's Workplace Outreach Wellness WOW package, which supports companies in rolling out general workplace health programs, including mental health workshops based on their employees' needs. The Ministry of Manpower, together with NCSS, is looking into improving the employment and employability of persons with mental health conditions and strengthening support for mental well-being at the workplace, such as better work-life harmony strategies and more job opportunities for persons with mental health conditions. More details on these will be released in the National Mental Health and Wellbeing Strategy in the next few days. Mental health is integral to overall health and well-being. There are plans in the pipeline to address mental health issues holistically over the next few years. With the release of the National Mental Health and Wellbeing Strategy Report, we invite the members of public to go through the report, understand the strategy and plans, and put up further ideas and suggestions for discussion. Thank you.
The question is that Parliament do now adjourn. As many as are of the opinion say aye. To the contrary say no. I think the ayes have it. The ayes have it. Pursuant to Standing Order 2, Section 3A, I wish to inform honourable members that the sitting tomorrow will commence at 12:30 p.m. Order, order.